Well, again, good morning. So we're going to talk this morning about maternal mortality and what we can do to help reduce or prevent that. And obviously only in 20 minutes I can't barely scratch the surface of this topic, but I'll try to bring up some points which I hope will be useful and interesting and practical for everybody in the room. And let's first look at this anesthesia-related maternal mortality rates. And specifically, this comes from the Triennial Report in the UK. And you'll notice that the slide ends here at 1996, where things were looking very good. The anesthesia-related maternal mortality, over these years, from the late 1970s up through the mid-1990s, both in the United States and the UK, was declining at a nice, reassuring rate. However, if you look at the most recent report of the Triennial Report from the UK, which was just recently published in 2008, and you look at the more recent years, here 2002, 2005, what you see is a very slight increase in the percentage of direct maternal deaths related to anesthesia. Now, the numbers are still very small. We can all be reassured that anesthesia is incredibly safe, but there's a very small increase in these deaths. And there may be many reasons why that may be. And maybe we can explore some of these as we go through this. Now, there are many things that we as anesthesiologists can do, and I just put up this article, which was authored by two of my colleagues at Brigham and Women's Hospital, Present and Emerging Strategies for Reducing Anesthesia-Related Maternal Mortality and Morbidity. And several of the things that I've highlighted in red here are practical things that we can take home. For example, we're always worried about the airway. On the other hand, we as anesthesiologists have gotten very good at securing the airway. We're very good at putting that endotracheal tube in, but don't forget that once the endotracheal tube is in, you've got to eventually take it out. And it seems now that emergence and recovery are now the most common times for airway loss. I'll show some data on that coming up in a few moments. I'll also talk about liability claims of medical malpractice, and the proportion of liability claims involving neuraxial anesthesia has increased. Ooh, the slides keep going off, okay? And then also the most recent trend, which I won't really talk about in any more depth here, is that of transfusion ratios, or the so-called 1-to-1 ratio of plasma and red blood cells, and now expanding that to platelets. So rather than some of the ratios that we used to use, most resuscitation anesthesiologists are using a higher ratio or proportion of plasma and platelets to our red blood cells. So specifically, let's talk about liability associated with obstetric anesthesia. This was a very nice review, which was published in the journal Anesthesiology just 2 years ago. And what you see here is liability claims prior to 1990 and then again after 1990. And some interesting trends come out, such as that maternal death and maternal brain damage, the liability claims for those have decreased, whereas there's been an increase in liability claims for maternal nerve injury. And this likely represents trends in our obstetric anesthesia practice, such as we have gotten much better at resuscitation, much better at securing the airway, but we're also doing much more regional anesthesia in patients with confounding medical problems, and that likely is the responsibility for these findings right here. Now, this is extremely important. Why do obstetric anesthesiologists get sued? And these are some of the reasons. They include anesthesia delay, poor communication, and substandard anesthesia care. Now, these are things that we can teach, we can improve on, and these are easy things to fix. It may be difficult to get the endotracheal tube into somebody with a difficult airway, but it should be easy to fix these kind of things. And these are things that we should be addressing as we teach our trainees to practice the specialty. So this article that I mentioned was accompanied by this editorial, Why Obstetric Anesthesiologists Get Sued. And this is something that I give to all of my trainees every year. I enforce that they read every word of this editorial because it's one of the more important editorials that I think has been written in recent years. And let's go through some of the points that are in here. The good news, whoops, we'll go back here. The good news is that there were no cases involving local anesthetic injection through intravenously placed epidural catheters. The bad news is that there were 10 cases of high spinal anesthesia due to intrathecally placed epidural catheters that were not detected by aspiration or the use of a lidocaine epinephrine test dose. So when we place intrathecal catheters, we need to use the utmost vigilance to make sure that all members of the team are aware of what type of catheter we are using. Anesthesia providers are not always adequately prepared to treat hypotension or an airway emergency when placing labor epidurals. We know that the circumstances surrounding the placement of a labor epidural may not be the same as with an operating room cesarean anesthetic, but the resuscitation equipment should be equivalent. You see here in 4 cases, patients had to be transported to the operating room for resuscitation due to insufficient supplies in the labor room. This is inexcusable. Regarding anesthesia delay, was alleged in 11 cases of neonatal death or brain damage. And this is something, again, that we can clearly impact with our communication skills with our obstetricians. When we really need to take some time with the anesthetic, it's important that all of our colleagues understand why, so we're not perceived as having the delay or being responsible for a delay in the case. Factors associated with anesthesia delay including inappropriately prolonged attempts to establish regional anesthesia and the anesthesiologist not being in the hospital. Anesthesiologists who take obstetric calls from home may want to reassess the safeguards they have instituted to prevent anesthesia delay of emergency cesarean delivery. And finally, communication counts. No question about this communication issue. More than 1/3 of the anesthesia-related deaths, cases of newborn death or brain damage, involve poor communication between the obstetrician and the anesthesiologist. This is a key point. While the obstetrician may have communicated poorly, the anesthesiologist got sued for the subsequent delay. Moving on, neatness and completeness count. Illegible, inaccurate, and incomplete records and poor English skills led to payouts in cases in which there was no possibility of an anesthesia contribution to the injury. And again, I tell all of my trainees, you've got to be neat, you've got to be clear, your notes have to be legible, because if you can't read them, people will assume things that might have happened. So we want people to know exactly what happened and not make any assumptions. Neatness and completeness count. So let's move on to another issue, which is one of importance to all of us, informed consent in obstetric anesthesia. This is a very new article. This came out just a few months ago in April of 2011 in the journal Anesthesia and Analgesia, and goes over a variety of issues related to how we get informed consent from our obstetric patients. Well, studies show that pain and opioids do not inhibit retention of information given during labor. In other words, you can get accurate and informed and credible informed consent during labor, even if a patient has had various types of medications. What do patients want to know? What do we need to tell patients? Well, this varies greatly. I know we have some data up here. We have a variety of studies on this, but really it is so individually dependent on the type of patient. Some patients want to hear everything possible. You see, all potential complications. Some only want to hear complications in which the incidence is greater than 1 in 10,000. Some only want to hear certain isolated complications. It's hugely variable and also, I think, very culturally dependent as well. Well, one of the problems is that when somebody is in labor, despite the fact that they may have received medications and are technically able to give informed consent, that's not really the best time to have a discussion like this. So ideally, patients will have learned about their anesthetics prior to labor, but we know that the antenatal education, in many cases, is given by non-anesthesiologists. Many patients come into labor with a whole variety of misconceptions, and we have to reprogram them or refresh their education during labor, not the ideal time to do that. So important antenatal education will improve the consent and recall process. What do you do in an emergency situation? Well, same thing you do in all situations, which is do the right thing. Do what's in the best interest of the patient and move on with it. But clearly getting truly informed consent in the setting of an emergency situation is not something that's very easy to do. And that's all I'm going to talk about there. Let's move on to this topic, which brings up the issue of airway. This was an important paper which came out just a few years ago, a series of anesthesia-related maternal deaths in Michigan, one of the United States, over this time period, 1985 to 2003. And the key point here is that all anesthesia-related deaths from airway obstruction or hypoventilation took place during emergence and recovery. Again, emphasizing what I said earlier, we have gotten so good at getting in the endotracheal tube that many times we forget that getting it out can be just as hazardous, especially if it's now been many hours into a case with a lot of blood loss and fluid shifts and edema of the airway. It could be that the airway at the end of the case is actually much more difficult than it was at the beginning of the case. So don't forget vigilance at the end of the case as well. Airways change during labor. My colleague, Dr. Bhavani Shankar Kodali, did this study where he was taking pictures of airways during labor. And you can see in this particular woman, over the course of a 24-hour labor, the airway dramatically changed. So sometimes if you see a patient in early labor, examine them and they have class 1 airway, for example, and now they've been in labor for 24 hours, it may be prudent to reassess that airway before an operative intervention is conducted. Airways do change during labor. Well, ACOG is the American College of Obstetricians and Gynecologists. They put out this document in 1992, Anesthesia for Emergency Deliveries. And I think this is one of the most important documents ever written by the American College of Obstetricians and Gynecologists. And they say several things that are useful even as we sit here today, almost 20 years later from when this was written. Risk can be reduced by careful antepartum assessment, greater use of regional anesthesia when possible, and appropriate selection and preparation of patients who require general anesthesia for cesarean section. Remember, the audience for this, the intended audience is obstetricians, not anesthesiologists. This is written and designed to be read by obstetricians. The obstetric care team should be alert to the presence of risk factors that place the parturient at increased risk for complications from general or regional anesthesia. I think this is just beautiful. Beautiful that our obstetrical leaders are telling our obstetrical colleagues that they need to know what we are concerned about as anesthesiologists. For patients at risk, consideration should be given to the planned placement in early labor of an intravenous line and possibly an early or sometimes so-called prophylactic epidural catheter. And finally, cesarean deliveries that are performed for a non-reassuring fetal heart rate pattern do not necessarily preclude the use of regional anesthesia. Well, we can enroll our colleagues in assessing the airway. This is one of my favorite studies. Obstetricians' ability to assess the airway, done in Pennsylvania, University of Pennsylvania. By the way, we have a colleague here today, also from the University of Pennsylvania, attesting to the international nature of this meeting. So this study looked at giving a brief training course to obstetricians and then having them assess the airways of their patients. And what was done here was they had 160 patients that had their airways evaluated both by anesthesiologists and obstetricians after this little training course that they were given. The attending anesthesiologist was considered the gold standard. And what was here, by the way, this is just two of our obstetricians at my hospital examining each other's airways, so we actually practice what we preach here by doing this. What was found was that after the obstetricians had a brief training course, they were pretty good. There was a reasonable correlation between the attending anesthesiologist airway evaluation and the obstetrician. And the point is that we can make our colleagues, whether it be obstetricians, midwives, nurses, we can make our colleagues aware of what we're looking for when we look down there in the mouth, and they can alert us when they see issues that may be concerning. Now, a new concept has arisen in the last few years that's been published and described. It's called Condition O. And let me describe what Condition O is. So this comes from this paper published in the American Journal of Obstetrics and Gynecology, Introduction of an Obstetric-Specific Medical Emergency Team for Obstetric Crises. So many hospitals have a so-called resuscitation team or a code team, code blue team. Sometimes there are even specific teams for certain kinds of patients, medical codes, surgical codes, neonatal codes. But what they're advocating in this particular article is the implementation of an obstetric-specific resuscitation team. And this was done at a hospital in Pittsburgh, Pennsylvania, United States. But now many other hospitals, including my own hospital, have developed an obstetric-specific code team. So here at this hospital, you have condition A, which is cardiopulmonary arrest. This is for all patients, not just obstetric. You have condition C, which is a medical crisis. Again, all patients, not just obstetric. But condition O, which is specifically the obstetric crisis. And the code team includes various members of both obstetrics, neonatology, and obstetric anesthesiology. This is who you get on code O, or condition O. You get a critical care medicine doctor. You get an obstetrician or a maternal fetal medicine specialist. You get a senior obstetrical resident. You get an attending anesthesiologist, and then respiratory, nursing, and various other administrative people. So an obstetric-specific code team, which includes obstetric anesthesiologists. Some of the reasons why you might call this condition O would include non-reassuring fetal heart rate patterns, shoulder dystocia, maternal seizure, moving on, difficult delivery during a cesarean, maternal syncope, cord prolapse, rupture of membranes in the ultrasound department. That's always nice when that happens. Hemorrhaging, placenta previa, and on the list goes. So these are some of the reasons why a condition O might be instituted. Now, at my hospital, we have another protocol, which I know my colleagues, Dr. Kodali, Dr. Palanisamy, are familiar with this, all hands on deck. And what we do with all hands on deck is we make a call when there is any sort of what we call obstetric surgical variance. In other words, anything that's just not quite right, whether it be with a vaginal delivery or a cesarean delivery, if it's just not quite right, and we have a variety of parameters, and I'll mention those in a moment, where we then call a so-called all hands on deck. And what that means, I think I've got a definition coming up here. We'll get to that in just a moment. So anyone on the team can call a so-called surgical variance, which basically means something is just not quite right. This goes in various stages. You see the various stages here. Can be taken care of locally by the team in the operating room, can go to the so-called all hands on deck, which takes all of the people that are working on the labor and delivery unit, brings them all together, and then we reassign resources at that point. It may be that, for example, one particular obstetrician is dealing with a hemorrhaging patient, but that obstetrician was also caring for several other women in labor. We need to assign other care providers to those women in labor so the obstetrician can take care of his or her hemorrhaging patient. So all hands on deck involves a dedicated beeper call to all obstetric anesthesiologists, not just the ones taking care of that particular case, all obstetricians, not just the ones involved in that particular case, all the midwives as well as the nursing leadership. We all gather together and then reassign resources appropriately depending on the circumstance. We also do various drills. We do drills where we practice this. We do this on occasion where we call an all hands on deck, but it's a fake one, not a real one. And what happens then is the people convene. We go through the motions of convening this, but we also have several observers. And the observers sort of sit in the side of the room. They have a score sheet, which you can see here, and we check off that various things are done. And that includes, as I mentioned earlier, communication, proper communication between members of the team. So we evaluate our own performance in this situation. There's more of the scoring sheet. And then at the end, we have a debriefing. All members of the team get together. We talk about what we did right. We talk about what we didn't do right. And hopefully we can always do better in subsequent times. But the point is we actually practice this among ourselves. So some points of note is that, again, anybody can call this. So the nurses as well as the physicians are on equal footing here. We really respect and welcome the input of the nurses as well as the physicians. We want to get all of the appropriate personnel in the hospital to respond. And each step goes in a sequential and logical fashion from the previous step. So it's an organized, logical sequence. And I think I'm just about out of time, and I think I've stayed just about on time. So I hope I've given you some practical points which you can use in your own practice, as well as some things to think about with regard to trends in maternal morbidity and mortality. And I'm happy to take further questions on this during our panel discussion. And thank you again for your attention.